Hola, ¿cómo están? Qué gusto que nos acompañen en esta
Hi, how are you?
sesión de la Semana Mundial de Alergia.
It's a pleasure to have you here in this last session of World Allergy Week. It's a pleasure to have you here. It's a program that we made with a lot of work, with very concerns. I want to thank everyone.
Ponentes extranjeros, un abrazo y reconocimiento, Eli. Y en esta ocasión, nuestra coordinadora es
And we have our coordinator, Dr. Sarita Espinosa, and she is an allergy specialist, immunologist, pediatrician from the National Institute of Pediatrics, and she is chief and in charge of immunodeficiencies research.
Muchas gracias por haber participado con nosotros. Y he de decirles que hoy es Noche de Chicas. Todas las
It's ladies' night. All our speakers are women.
De Monterrey.
We have good representation from Monterrey. So thank you everyone. Sarita, you have the floor. Thank you, Benjamin. Good evening, everyone. We're very happy because we're closing this week in anaphylaxis. Thank you, Benjamin and Eli. And let's start, as Benjamin says, with our first speaker. We have this last day, closing this week, and our first speaker today, we have Dr. Elizabeth Estrada Reyes. She is a pediatrician, allergy specialist from Hospital Ángeles Metropolitano, and also as a clinical researcher in allergy and food allergies. She has a master's in medical sciences by Politécnico Nacional and the General Hospital of Mexico. Dr. Elizabeth is a member of Compedia. She is a member of the European Academy of Allergy and Clinical Immunology and the National Institute of Pediatrics of the Spanish Society of Clinical Immunology and Allergy and the British Society of Allergy and Clinical Immunology. We're going to learn about difficult allergens. Thank you, Dr. Elizabeth.
Hola, buenas noches. Buenas noches a todos.
Good evening.
No veo mi pantalla.
Solo comparte y no te hago aviso.
Ok. Ahí está.
Okay, here we go. We're ready. I want to thank everyone here. I want to thank Benjamin because he gave me the opportunity of being here to design all the program. It has been very good. It was long, we're tired, but we're so happy. We're going to be talking about anaphylaxis in food allergies, complicated food allergies. You can see my screen? Yes. Yes, okay. Yes, just like that. We're going to talk. We have to reaffirm this mechanism. The loss of this oral tolerance has to do with intestinal patency. When we have this problem of intestinal patency, it's easy for the allergen to penetrate on this epithelial cells. And when it goes through this epithelial cells,
digamos que estimulan esas células.
It stimulates the epithelial cells to start to produce interleukin 25, interleukin 33, lymphopoietin, stromal, lymphopoietin, and with this, it starts changing the phenotype of the dendritic cells. With dendritic cells that are going to be pro-inflammatory. With these dendritic pro-inflammatory cells, they're going to migrate to the nodule and they're going to have allergies. It's going to be presenting the allergy and obviously is going to start to have that type 2 response. So it's going to stimulate with the presence of interleukin-4, they're going to stimulate the naive T cell that is also going to stimulate, and it's going to start presenting the stage 2 cells that in the presence of this interleukin-4, 5, and 13, they're going to make the switch with the B cells. And these B cells, what they're going to be doing is that they're going to make the isotype of the specific IgE. The specific IgE is going to be fixed in the mast cells and basophils, and then we start to release chemical mediators, and then we start with the entire inflammatory process. Let's talk about this food allergies that have become into a health problem that has increased in a very concerning way, covering a broad spectrum of diseases. It has been varied, but that diversity is going to be because there's going to be so many factors that are going to have an influence for this to be more diverse and more frequent. One of the things have been the immune guidelines that obviously we know that are IgE mediated. So the natural history has to do with the presence of the allergen and the time in which this is going to be presented, you know, the symptoms, the type of food, the matrix of the food that has this, if it's raw, if it's cooked, it has to do with being more or less allergenic. The exposure, right? The ones that we know we're going to be checking, comorbidities, that we know that there's a risk of having more anaphylaxis. If we have cardiovascular disease, asthma, or recurrent infections, because when they're mainly females, then we're going to have certain situations where they're going to be more prone to anaphylaxis, and the cofactors that we have gone over them throughout the week: alcohol, 13%, the exercise, 10%, and also medications as well. Now let's go to the natural history. It's very important because in young patients that have milk allergies or egg allergies, we have seen that most of them reach tolerance in the first few years of life. And as I mentioned, this has to do if the allergen is going to be tolerated, cooked, and in the case of egg, we know it's complicated to start tolerating raw egg. But what is this going to depend on? That we can have, most of them are going to have tolerance, but some are going to be persistent. How are we going to see what factors are going to tell us that there can be resistance? Well, the increase of the specific IgE for milk or egg, instead of going down and that we get to this cutoff point that maybe is going to say that we tolerate, we can have an increase, or maybe to have a respiratory comorbidity, it also can be some of the indications that can make us you know, that can tell us that it's resistant. Maybe peanut allergies or seafood is going to be early onset, but it's going to be persistent as well. Then here we can see how we start tagging them as hard allergens or complicated allergens. The sensitization guidelines that we all have, that sensitization by class 1 allergens, that is going to happen with the food proteins that are stable to digestion, heat, enzymes, and this sensitization can be GI way. And obviously the icon of all of this, the proteins continue. There are these LTPs. We can find them in fruits, vegetables, and some cereals, even in peanuts. The other one is class 2. that is going to become sensitive the airway, and some proteins that are more labile that can break easier. And here we're going to be sensitized in a respiratory pathway. That's the classical type of the relationship of pollen food, like oral allergy syndrome, that it's involves prophylines. And basically this other pathway, new pathway, that the truth of the matter is that has not been studied as much as the skin pathway. Those young patients that have atopic dermatitis can have mutation in the filaggrin gen. What is this good for? Because to have continuity of the skin and to have water. So if we have that mutation, we're going to be a loss of continuity of the skin. And we have seen that patient that have emollients with peanut, with egg, that's going to be the pathway where we're going to have allergies. As a conclusion, we can see that the skin can promote food allergies. However, the intestine is the one that is going to promote or develop tolerance. We have seen that patients where they have seen that patients that are in contact with the skin, with peach, they can have urticaria. It could be a pathway, even if we have not studied. We go to the phenotype. Lately, we are seeing in food allergies that these phenotypes, let's say we're proposing this as if it was one of the assessment that I'm going to have to make a more accurate medicine, that I'm going to have to it more personalized in the treatment with patients. So here we can see why these cohorts are good for the icon that it has been studied the most, has been held not, that found this egg, peanut, and some others like Manchester and the German study. So what we have seen is that the phenotypes persist, the ones that are going to be there, that are going to be atopic dermatitis without sensitization, those that are going to have egg allergies, or those that have other phenotypes, multiple food allergy, but more peanut, and those that are going to have multiple food allergy plus eggs. So this other cohort that it's from Belgium. They found about 30% of association with the peanut anaphylaxis. This paper I wanted to show you because it's the entire anaphylaxis profile for children and adolescents. This was done throughout Europe, which was the NORA trial. And talking, was thinking that with the level of evaluation and classification that Dr. Torbert said, because he was, Professor Rink was saying, he's the one that did it, but it provides us a lot of information. And we have seen, for example, that comorbidities in the patients, in younger patients from birth all the way to 6 years of age, it was atopic dermatitis. In children, adolescents, it was rhinitis and asthma. As cofactors, they presented the exercise. And where did we have the event? Well, it was at home. Out of the allergens, like the ones that are the culprits of presenting anaphylaxis, is really interesting because in those preschool children, probably egg and milk, it was peanut and sometimes nuts. But in patients 6 to 12, the most frequent was insect bites. And in some other adults, it was allergies to medications in preschool children. We saw it more in food, in the school-age children, also food, but it goes down and it starts increasing the insect bites and medications, and in adolescents, a little bit more the medications. Symptoms that were more persistent was in those preschool children, GI symptoms, patients that were school-age children with respiratory, In adolescents, we saw that it was increasing more and more neurological symptoms and cardiovascular. So it's really interesting what is the symptoms that we expect or what type of allergen we're going to be expecting in the patient that starts with anaphylaxis. So this is another phenotype that Dr. Turner had, and they saw that foods were more frequent if they were considered to be school-age children. And those reactions were in the adolescents, and they had more respiratory symptoms. And with medications, and they had it more in adults, and there were symptoms that were cardiovascular symptoms. And in adults, it was that they had the fatal reactions. And in insect bites, was everywhere. And it was in adults, and it was cardiovascular symptoms. And for us to really be guided and what the patient can present with, what are the factors that are going to have an influence in this severity of food allergies. The specific threshold dose is enough amount of foods to present symptoms, and we know that it's going to be priority with time because maybe it's going to have some tolerance, and that threshold dose is going to vary. So this is more oral than cutaneous, and the severeness is more. Those patients that are going to have with intact proteins are going to have more problems. LTPs or storage proteins. We're talking about the minimum specific dose, the minimum threshold dose that definitely it's important that we're trained properly to know when the patient is going to start with subjective or objective symptoms, and that we don't get here to present anaphylaxis. So I wanted to show you this because food consumption, the food is going to go to the stomach. And in the circulation very quickly, the mediators are going to be released, bronchospasm or cardiovascular symptoms. I wanted to show you this slide as molecular diagnosis because I know that we have pediatricians and medical students, so it's important molecular diagnosis in order to this molecular diagnosis to be good for us because it's going to describe the profile of allergy sensitization with the determination of a specific IgE. It's going to describe the smallest part where the patient is going to react. And it could be two types. The allergy source, that it could be natural to the native or purified, or can be recombinant, that can be coded with the DNA. How is this? Well, it's a binomial system that describes the gender, 3 to 4 letters, and the allergy is going to be followed by numbers as they're presented with time. It can include an R profile that could be a recombinant profile, a purified molecule. So why do I need this molecular diagnostic and when should I use it? It can be attractive, it's expensive, and we need to really consider when we should be using it. And here we see when there are differences in that sensitization, whether it's primary or multiple, so we can get rid of all the questions and we can find what really is happening. And it also going to allow me to assess future systemic reactions like the LTPs or the protein, the storage proteins that I mentioned, because that's going to tell me, well, that's going to tell me that it's going to be a worse outcome or not as bad. And when we saw the presentation about idiopathic anaphylaxis, what was the trigger? Let's just see in this part about the LTPs. Rosacea, that is going to be peach, Prunus persica, and that means it's Pru P3. Apple, Mal D3, and so on and so forth. When am I going to be using it? Fortunately, we have this classification, those patients that are going to have this allergens, high risk. In the group, we have LTPs, storage proteins, PR10, without suspecting that this is going to have high risk of anaphylaxis. And those that are going to be low risk, which is PR10 or what? I wanted to show you this because the ones that I mentioned are here, but here they include everything for the insect venom that have the risk of anaphylaxis, LTPs, allergens that have been identified in food plants, rosacea, fruits, vegetables, nuts, cereals, latex, artemisa, banana, and some others. The ones that we see, they have two chains, molecular weight of 7, and what are the phenotypes good for? The largest cohort, the patients with LTP in this Italian cohort, 538 patients. 80% were sensitized more to this and 71% to R3, that is nuts. But the interesting thing here is that those that had more LTPs were going to have anaphylaxis, or those patients that were positive to Artemis, they were going to have, besides anaphylaxis, they're going to have respiratory symptoms. However, this LTP of Palitaria, PR10, or paraphilins, and I wanted to show you the ones that we could have an anaphylactic shock with eating apple. There was no cofactor, only the patient referred anaphylactic shock with the apples. Skin tests were done for LTP extracts and molecular diagnosis. Cofactors like ibuprofen, and with the molecular study, there were several allergens, and the patient had to get a challenge test and had symptoms. It's complicated because definitely we have to see how we can see the outcome for this. So there's our clinical trials with vaccines for against LTP. The first study or trial, there was no significant difference. And the second one, instead of benefits, there was more side effects. So it really didn't help. What they're trying to do is oral immunotherapy with peach juice that is giving good results, like oral immunotherapy known and that has been reported to tomatoes. It looks like they improve. Another complicated allergen is peanut. And peanut develops in the early stages of life, and it's going to resolve only 20% when they get to a certain stage. In the United States, Canada, Australia, UK, they're the ones that have more reports. It's affected in children 1.83%, in adults 1.32, 1.8. And treatment obviously is exclusion diet or elimination diet, adrenaline, but we run the risk of accidents and that's going to affect the quality of life of the patient, of course. What we have seen, and is really interesting in peanuts, that the patient can have mild symptoms with the intake of the same amount, and then the following time when they intake, the patient can have symptoms with fatal outcomes. So what happens? Induce oral tolerance. We can see here it's going to have a broad array, like Blanca Martin mentioned this. We can have profilins, PR10, LT10, but the ones that are more risk are going to be the ones that are the storage proteins. And here the iconic one is going to be LH2. Another study of phenotypes, so we can classify. In the United States, they report a persistence of 9% of CRH2. In Spain, even though they have 1 to 3 to 6 in the dose of globulin, and in Spain, at a 60%, Sweden, RH 65%. These three countries are the ones that report more severe reaction with peanut anaphylaxis. In Eastern Europe are H1, 3, and 6, and PR2 for allergens, and the reactions were very severe. Based in the studies that we have from everybody else, not only we have something that helps, like the prick test, ARA H2 have a cutoff point with high specificity and sensitivity, and degranulation of basophils is very useful, and they have a cutoff point. In treatment, there's no immunotherapy that is used all the time. Many attempts subcutaneous immunotherapy with side effects, with raw extract, oral immunotherapy with peanut that we know that it should be 80%. And this has been seen as working a little bit more. Or the epicutaneous, that is the one that is a little bit difficult because we need to be changing the patch with the patient, the use of omalizumab with the formulas of herbs, and that is based in toll-like receptors. I wanted to show you this because the one that I was telling you about is the Palisade study, the Parforcia, and they were able to desensitize up to 84% with side effects of 81%, but that's not bad. And with the patch, we were able to get 67% omalizumab. That gave really good results, and often it can give us both oral immunotherapy with the application of omalizumab. Omega-5 gliadin, we have seen that wheat is one of the most common ones in anaphylaxis in adults. The largest record is a European record of anaphylaxis, 10,633 6 patients, 213 adults, and 37 children. It's very important, the presence of cofactor. 84% it was found. And 87% presented cardiovascular symptoms, loss of the stage of alert, and respiratory symptoms. And they refer that the reaction to wheat is higher, more than the insect venom and medication. Omega-5 gliadin is a storage protein that is Latria 19. I wanted to show you that not only wheat is the omega-5 gliadin, profilins, more problems in this case of anaphylaxis by omega-5 gliadin caused by exercise. Really, the pathogenesis, we see that when they exercise, there can be changes in the intestinal patency and to redistribute the blood flow. To start, this omega-5 gliadin syndrome. It's part of the other one that is exercise-induced anaphylaxis with any food. But as I said, cofactors are the most interesting ones. It could be exercise. One of the hypotheses is that increases intestinal absorption, NSAIDs, intestinal patency, and alcohol, and increase in the release of histamine. So this exercise-induced anaphylaxis that is food dependent, it's a lot of things: seafood, vegetable, fruits, nuts, egg, meat, beef, that it could be, delayed reactions. The patient reactivates or is activated with exercise and presents all of this anaphylaxis. And also, if they finish exercising and they take the food, they start with the symptoms. Diagnosis is challenge test that should be given 100 grams of wheat flour, exercise, avoid exercising after the intake of wheat, or if the reactions are severe, it's better to avoid the allergen completely. To close, here we have learned, and I took this out of the Australian Association, that we know that this doesn't mean that anaphylaxis, we're going to have just like this. It can happen with all these symptoms. I'm showing this so you can download this, because there's some protocols in Mexico. Read this, go over it. It's free regardless of the guidelines. There's a lot of information. And here, CONMAMED, the one that had the initiative was Dr. Chuley Leija. And this is for you to have the protocols. It's important, really, to prevent, and hopefully we can have the self-injecting pain. Thank you.
Muchísimas gracias, Eli.
Thank you, Eli. Thank you for your presentation. We may have some questions, and we're going to send them on the Q&A icon. Please answer on the chat for Q&A. Thank you, Dr. Elizabeth Estrada. And now we have Dr. Alejandra Macías. Dr. Ale is known by all of us, and she's going to talk to us about allergies to Hymenoptera and anaphylaxis. She's professor at the School of Medicine at the University Hospital at the University of Nuevo León. Ale, you have the floor.
Muchas gracias a Compedia por la invitación.
Thank you, Compedia, for the invitation. Dr. Paco Espinosa and Dr. Benjamín Cepeda. Today we're going to talk about Hymenoptera allergies in this World Allergy Week. The first report of anaphylaxis in the world is the death of Pharaoh in Egypt. But this is controversial. Egypt specialists are not in agreement. They said that the Pharaoh died because of a bee bite. Is because we see this image, the semicircle, and then it's replicated in other parts of the scripture. And this is how these figures look. So it was interpreted as a bee, and that it had caused the death of Pharaoh. In other Egyptian scriptures, it's a little bit different, the shape of the bees. And it's controversial because Egypt specialists say, they cannot come to an agreement. Some say that it was a crocodile, that's his dog, so nobody knows. That was the first event of anaphylaxis. It was because of the bite of a Hymenoptera. Epidemiology, world prevalence to the allergy of Hymenoptera venom. It varies depending on the reference, on the way it's diagnosed, and it goes from 2.4 to 26.4 in the general population. But these systemic allergies are more frequent in adults and in children, and a risk factor of an older age is the presence of persistent cardiovascular diseases. Men have a higher risk of severe reactions. The allergies represents 10% of all cases of anaphylaxis, and within the cases of allergy to Hymenoptera venom, we have the representation of almost 20% of anaphylaxis. And from another point of view, within the patients with mastocytosis, about half is a trigger in the allergy to Hymenoptera venom, from 0.03 to 0.48 cases per million of inhabitants. We have seen a genetic defect in having severe anaphylaxis can be present in those that have allergy to the venom Hymenoptera and that have severe reactions. In those that have systemic mastocytosis, and in the future, it could be that someone can have a marker that is used in an intentional way. About Hymenoptera, we go to the taxonomy. They belong to the animal kingdom, to the class insects and Hymenoptera, and these are going to be divided into large families. Apoidea, where the important representatives are the bee and within the family of the wasps, we have these families, Apidae, Bombidae, and Respidae. We have wasps and the representatives, and within the Formidae, we have fire ants and others. Talking about the taxonomy of Hymenoptera, they're going to be a body that is sectioned in three. The limbs are going to be in pairs. They're going to have 3 pairs of legs. They are going to have appendix with wings, not necessarily all of them, but it's common. And something that they're going to be presenting is the production of venom. The venom has different components or toxins. We might think when there's a bite, you know, that this is mediated by several of these toxins, but the most severe thing, it would be the anaphylactic reaction, anaphylactic shock. But we can also have some other effects at the level of the muscle, of the blood cells. We can have hemolysis. It can have kidney failure, alterations of the nervous central system. We're talking about bees. These are herbivore. It's important because not all Hymenoptera are herbivores, and the body is hairy, and this is going to allow for all those hairs trapping the pollen, and that's why it's important that we acknowledge what the bees do and how we're caring to try to preserve them, because a good part of pollination depends on insects like them. They're not aggressive animals. They usually respond in the defense of their hives, their queen, and the bites are going to be accidental. There was a project in the 50s where they try to cross African bees with the American bees. And the African bees were more aggressive. And with this, it has taken us to a severe problem that has even gone to movies. They have migrated from South America to the United States, mainly through cargo boats, like we will see what happened with the ants, and pretty much the entire south of the United States has been taken. There are attacks from these bees. Unfortunately, I didn't find more updated images, but we can see how they have moved. In Arizona, they have a severe problem. This is an article from Arizona. We can see the image of a nest, because when they move their nest, they travel like this in group, and then they can settle in a tree branch. In Mexico, we have to call and look for specialists to try to move them without damaging them and taking them to a place where there's no problem. They have put together a report 2.5 years ago where the bites would go from 1 to somebody that was bitten by 950 bees. The bee, when they bite, the back part of their body breaks down and the bee is going to die. Different from other Hymenoptera that can bite you several times, the same one. So this 950 bites were 950 bees that attacked this person. Even with this violent attack, this person did not die, was hospitalized with a moderate effect of this. They were only bitten once, so they were allergic. We can see acupuncture with bees. The incidence of adverse events is very high, almost 30%. Also, with the local reactions that we could expect. Even neurological manifestations like Guillain-Barré syndrome, cardiovascular, hematological. It's important because this should not turn into a practice that is there because it's a big risk for the patients. Now we go to the aggressive part of Hymenoptera, like wasp, yellow jacket wasps, and different from the bees. They live on the soil, or they tend to look for places in caves or in tree holes. They're very aggressive, even with a minimum provocation. Close to their nest, they can attack their carnivore, and they can bite several times, different from the bees. You always learn something when you put together a presentation, and this is what I learned. Something interesting that I learned from this presentation. Some species need a small wasp, Clastophaga senes. It's very small, 3 ml. They need this wasp for starting their flowers. And what's interesting for me is that the inside of the fig are the flowers. So the wasp goes on this side, the female, and she's going to lay her eggs. She has already been fertilized by the male. It's a suicide attack going into the fig because she's going to lose her wings. She's probably not going to be able to leave. So she lays her eggs, and the males fertilize the females that they find, and they don't have wings. They're going to die, and they're going to be part of the inside of the fruit. The females are going to go out, and they're going to continue doing what they had to do. What's interesting, this lasts about 2 months. There can be some rest of the insects, it's a very remote possibility, but it can happen. There's a report of somebody allergic to wasp venom, that when they were eating figs, they had symptoms that are similar to oral allergy symptom, and they presented with anaphylaxis. The search was thinking that they were allergic to figs, and it was not allergic to figs, but yes, to the venom of the wasp. And they found that there were microscopic amounts of proteins of wasp inside the fig. This is also one of the reasons why they're strictly, the ones that are strictly vegan, they reject the figs because there could be microscopic amounts of wasp meat. Some of them are really big. There are only 55 cases of anaphylaxis by a hornet bite. What is really scary is the mortality rate of this 55 cases. 40% died because of an organic failure. This is a map of the attacks and the varieties of hornets that have caused these cases of anaphylaxis, some cases in the Americas, and we have to be paying attention. In Monterrey, there was one of these cases, and they studied this. They were not able to show that it was the most aggressive ones, but if you see them, just keep away. With respect to ants, when they bite, they're gonna cause a pustula like this. You can see it's sterile. Some of the allergens have been identified that can be common in other variety of them, like the ant fire. There's another one that is Hypnosis ripteri, and they can have a cross reaction. With Solenopsis, it's like with the African bee, they have migrated from South America to the United States, mainly through with boats. So the coastal area is the one that mainly was affected. We have it in the northeast of Mexico. They have found some Solenopsis nests, and we have to take this into consideration. We have seen these floating islands of ants. They're organized and they put together these islands and they float, and they found a place to live. The European community sends this flow chart and systemic reactions to the bites. They suggest, skin tests, serum tests, and depending on the results is the road to be followed. If they identified that is one single Hymenoptera and is positive, then immunotherapy would be recommended that is specific for that venom. If there are two, we need to make sure that there's no cross reaction, in vitro test, and molecular diagnosis. In the case of wasp venom, if they're negative, best B1, best B2, a real allergy to wasp venom, so I would not recommend immunotherapy. In the case of a bee, if only APM5 is positive, it's possibly that is a cross reaction with the venom of the insect, so it's not recommended to start immunotherapy. The sensitivity is not so good in the case here. If it was negative, we would not rule out allergy to bee venom. We need to perform values to see if we need to run any other tests like basophils. And if everything is negative, to consider some other reactions. We must consider within the differential diagnosis of idiopathic anaphylaxis, sensitization to insects or parasites, particularly when symptoms are not anaphylaxis or where there's an environmental situation and where there's the season. Hymenoptera bites are going to be in the spring or the summer. We're probably not going to find them at any other time. In order to diagnose with the components, we know some of the most important allergens. In the case of the bee, there are 12, and the most important one is phospholipase 2. And we are going to see that it's important because it's going to be a phospholipase in the case of the wasp. In the case of the yellow jacket, and this is papelera wasp, but that has a phospholipase that can have a cross reaction with the bee antigens. In the case of Solenopsis, there's a phospholipase that also can have cross reactivity with the wasp. And here we can see those crossings where the bee with a hornet are the ones that are going to have the most important crossing, and also less bee with wasp, with hornet. Once the bite happens, we need to establish if the local reaction is big, if it's systemic, or if by accident the reaction, the sensitization, it was less than 10 centimeters and there are unusual reactions. When that's the case, well, then it's not recommended to use immunotherapy with the venom, because when we have big reactions with more than 10 centimeters, more than 24 hours, when it's between 10 and 15, immunotherapy is not recommended. When it's around 15, they're recurrent and there are problems, we can consider the use of immunotherapy. In the case of systemic reactions, when they're limited in the skin and they do not affect the quality of life, then it's not considered immunotherapy. When they do affect quality of life, the immunotherapy is recommended 3 to 7 years. When systemic symptoms are moderate, dizziness, the dyspnea, nausea, immunotherapy 3 to 5 years. And when the symptoms are severe, immunotherapy has to be at least 5 years, but sometimes it's recommended to do it for life. Recommendations for immunotherapy is going to be children and adults, and there's going to be an hypersensitization of systemic reactions that go over the symptoms that are skin. Even in adults that can have skin symptoms, but the quality of life is there, but is affected, but it could done when the local reactions are a problem. In the case of adults, is not recommended, as we saw in those where we saw the sensitization is incidental, or when there's no genic symptoms, or when the reaction is immediate. You have to be careful when there's cardiovascular disease or it's specific for some organs. They have to be stable before starting immunotherapy. If the patient have ACE inhibitors, then we need to assess if it's important to continue with immunotherapy. Always give the patient all the information about the potential risks. When are we going to give them immunotherapy? When there's a malignant disease, autoimmune multisystemic disease in children under 5, even if the children helps and they can understand what is happening and not indicated during pregnancy. The type of immunotherapy, it's going to depend on the manifestation. When the anaphylaxis is 3 to 5 years, but in this level of severity, it could be 5 years or for life. In patients that are allergic to bees, that are the ones with more risk, and in those that have mastocytosis. Some biomarkers help to establish the severity of the reactions. And how is the patient going to do with immunotherapy? It could be the main marker, like in the case of anaphylaxis, that's the one that allows us to measure more time. But it's the basophil test that has more correlation with the severeness of the reaction and how is the patient going to respond to the immunotherapy, whether they're going to present adverse events or not. Unfortunately, it could be 5 to 8 nanograms, what has been reported, that is going to be associated with the severeness manifestation. An alternative that we've had for some time, is the use of monoclonal antibodies, anti-GL, the olimizumab, in those patients where it is not possible to move in immunotherapy because of the reactions that are present. Bevacizumab has allowed to be safer the use of immunotherapy in these patients. With time, we're going to be able to test efficacy of the other biological agents that are there. This is a matter of time. This is a trial from Italy that is really interesting about how patients do in real time with the patients with immunotherapy with what's venom, only 23 patients, but they were followed up for 5 years of immunotherapy and 8 follow-up 13 years, where they were exposed, they were accidentally exposed during the time that they were with immunotherapy. Nobody presented severe reactions, and the number of bites and the level of severity of the reactions. This is during immunotherapy. In follow-up, most of the bites only gave mild symptoms that didn't need more management. And with some of the markers, we see that skin reactivity of the tests throughout the time of immunotherapy, there was a size, and as months went by, almost at the end, it went down in an important manner, and this reduction persisted even during follow-up without immunotherapy. The same thing happens with the IgE specific levels. We see an important reduction, and they stay in the follow-up stage. IgE4, we know it's a marker that talks about the efficacy of immunotherapy, and it means that it goes up and the time that they receive it, and then in the stage of follow-up. This drop did not mean more risk for the patients or more severe reactions, as we saw in the prior slide. It is a marker that talks about the response of the patients to immunotherapy. We can see that does not go hand in hand with the lack of clinical efficacy. And during this the pandemic, it has been a problem for the patients with immunotherapy to be able to use it, because this should be done at a hospital. This is not a medication that they can use at home. So sometimes there are times between applications that are longer than what was needed. So they found that in general, the patients did well. Most of them were able to continue with immunotherapy. Only they recommend that they're careful, because before the pandemic, they had long time maintenance, because in them it's not easier to have symptoms, because they had a history of severe reactions that they had just started, polypharmacy, or they're allergic.
Algo interesante también es la relación que guarda la alergia al veneno de Hymenopterus y el distrés psicológico. Esto como parte
And there's a relationship between this and the psychological stress. High levels of anxiety with respect to allergy to the Hymenoptera. And we are more concerned, and men do not carry their emergency medication, but they feel safer when they use it. And with this in mind, with neuropsychology and the allergy to Hymenoptera, the relationship of anaphylaxis and the allergy to this venom with the bite of a Hymenoptera and to get anaphylaxis is very stressful. And when you see the scale to see the post-traumatic stress, obviously patients with anaphylaxis are going to have a level that is higher of post-traumatic stress than the patients with trauma. But it's interesting because those patients that had anaphylaxis, but they had an event that was traumatic, that somehow put their life at risk, have more post-traumatic stress and more anaphylaxis with Hymenoptera than those that did not have it. So this column are those patients with anaphylaxis and that have suffered one or more events. And we can see that this is a ratio of almost 3 times more against those that also suffer anaphylaxis and that have not suffered something that was life-threatening. The hypothesis here is that the stress that accumulates throughout life not only is a bias towards TH2 with the elevation of all the biomarkers of this phenotype, but also that it increases the risk of anaphylaxis for these patients, particularly the venom of Hymenopteri. So recommendation is to follow with the patients, not only in the clinical aspect of what to do with their allergies and to have their medication, but also to provide psychological assistance because of the impact that this has in their lives. Some recommendations to avoid Hymenoptera bites. This usually matches the reproductive period. It's kind of sad because they limit your life outdoors. That's one of the recommendations. Do not eat or keep foods outside. So we don't attract the insects. Avoid walking barefoot. Use shoes that cover the feet. Avoid keeping garbage around the door. Do not get close to the garbage. So avoid bars and restaurants. Avoid going to markets where there could be foods or things that attract the insects. Avoid opening doors and windows, and if you have to use a mosquito net so they don't go into the house. To use traps for insects inside the house. Do not use any deodorizers or that the patient uses perfume or cosmetic products with fragrances. Do not use cleaners cleaning products that have a smell that could be attractive. Avoid clothes that makes us look attractive to the insects. No intense colors. Do not keep fresh flowers at home. Avoid the consumption of alcohol. Do not hang the laundry outside because the insects can hide. Avoid the use of public restrooms and cover the body. And that's all that I have. And this is my email. If you need the presentation of any of this information, it's going to be a pleasure to share with you. Thank you, Ale. Excellent presentation. And I think everyone or a lot of us learned so much about figs today. Thank you. And questions that you may have for Dr. Ale, please, in the question and answer icon, and Ale is going to be helping us to answer these questions.
Como nuestro siguiente ponente, tenemos a
Our
la
next speaker is Dr. Sandra Nora González Diaz. Dr. Sandra Nora is Chief of the Regional Center of Allergy and Clinical Immunology at the hospital at Center. She is the chief of the Center of Hospitalization since October 2019. She's president of education and training of the World Allergy Organization from 2020 to 2024. She's member of the Council of the World Organization of Allergies, ex-president of the Latin American Society of Allergy, Asthma and Immunology, ex-president of UNASMA in Spain and Latin America, and Dr. Sandra Gonzalez is going to talk to us about anaphylaxis during pregnancy. Thank you, Dr. Sandra. Thank you. It's a pleasure to participate in these webinars and conferences under the frame of the World Week of Allergy and with the topic of anaphylaxis to understand what are the different possibilities according to this mechanism, particularly the education that we are performing, supported by the World Allergy Organization, WAO. I'm going to share my screen now.
Bueno, tal como lo mencioné hace un momento.
As I mentioned, in this World Allergy Week, I'm going to be talking to you about something that is very important within the expression of anaphylaxis during pregnancy. We have mentioned this over and over. We have made campaigns, programs throughout the world specifically, and something that is interesting for me. I'm going to start with a clinical case of a patient that I saw some years ago. It was an asthmatic patient, not well controlled, and she was 8 weeks pregnant. She goes into the emergency center and trauma center at the hospital. And as I said, very consistent in everything. She mentions that she was doing housework, and then all of a sudden she felt bites, and she saw it was ants. 5 minutes later, it was generalized malaise, and she had difficulty to breathe, nausea, heart rate of 117, just breathing 24, temperature 36.5, and under physical examination, it had 12 to 15 papilla in legs and arms, pain. She had bilateral wheezing, also GI system. She had nausea, abdominal pain, tachycardia, hypotension, and the CNS. She was anxious and confused. I'm going to leave the case here, and then I will discuss this later. But I have to mention and emphasize in the definition of what we have talked about before, the different hypersensitivity reactions that are represented, like patients in our specialty with a quick onset, and that can be potentially deadly. Many triggers, and according to what we just saw about insects, it's interesting, but it could be medications, it can be foods, and other series of situations that are presented as a non-immune mechanism. Vulnerable groups, age groups, children, adolescents, elderly, and pregnant women. So according to this position statement in the guide for anaphylaxis at the WAO. And it's not uncommon, but it's underdiagnosed. And the studies in small groups are not enough. In Canada, there's a group in this respect. Death is catastrophic because not only are we talking about the mother's death, we're talking that we have ischemic epoxic encephalopathies, and the damage to the CNS is permanent, as I mentioned. It's not so frequent, but in the UK, according to this revision in OBGYN of Macau a few years ago, 1.56% of every 100,000 pregnancies, 54% of this group of patients had allergic reactions with a history of atrophy of 43, and 5% of them had anaphylaxis. We see the incidence of pregnancy in the different countries, Europe, France, Belgium, and the combination of some of them with the percentages per every 100,000 inhabitants with a mean of 1.5%. In the United States, they report 3.8 of every 100,000. In Mexico, in many places in Latin America, we don't have the exact result because of the anaphylaxis. We have to mention, with respect to the risk factors, what we should consider. What are those factors that take us to this possibility of anaphylaxis during pregnancy? A procedure by because of a C-section, and these odds that are adjusted, the history of an allergic reaction compared to those that do not have it, African Americans, Caucasian, there's also a difference. What are the triggering factors that we must consider? Well, the first 12 weeks are the most difficult and complicated ones, where this time period, like during labor and during delivery, anaphylaxis is the same as in the general population before the birth, antibiotics, medications, vaccines. After birth, we have the ingredient of anesthetics or the history of the NSAIDs. We have mentioned among the causes, antibiotics, penicillin, sulfas, and some other antibiotics, Zipsometonic. They have been identified as one of the causes in this group of patients. What can we say about the signs and symptoms I mentioned earlier in a clinical case that we had, that it could be in the skin, urticaria, angioedema, rash, periorbitary, vocal. It could be symptoms that are simple or frequent, rhinorrhea, sneezing, larynx stridor, dry cough, dyspnea, wheezing, GI, very frequent. Like in the case of this patient, the pain and nausea, vomiting, diarrhea, or dysphagia. Cardiovascular, arrhythmias, bradycardia, hypotension, tachycardia, palpitations, anemia, incontinence, fecal or urinary. At the cardiovascular level, headache, altered vision, alterations, some of the manifestations of alterations of the dental state, dizziness, or a feeling of imminent death. Within the clinical criteria, according to the Allergy World Organization, or World Allergy Organization, we have a situation where it can be presented in a few minutes and hours. It can be characterized in this case by skin manifestations, and that can have a compromised the mucosas. They could have some kind of respiratory compromise, as we can see, related to some symptoms of dyspnea, wheezing, and everything that we have mentioned. Arterial hypertension, symptoms of a circulatory compromise, where the circulation can be affected, of GI symptoms. On the other hand, also, we can have hypertension, bronchospasms, and the larynx manifestations when there's exposure to a known allergen. And in absence of cutaneous symptoms, any possibility in the age group of children, in the group of adults. On the other hand, less frequently, but we have seen in this participation of Michael Chats and Simons in Jassy a few years ago, exercise, and something else that is very interesting, 72 hours postpartum, lactation, and it's attributed to hormonal changes or to the rapid diffusion of progesterone. Clinical manifestations that are more common during pregnancy. It could be, as I mentioned, acute initiation, quickly progresses, not necessarily it has to have hypotension or shock. It could be an area of erythema, rash at the vaginal area, a colic, distress, preterm delivery. At the skin and mucosa, the manifestations have more percentage, up to 90%. In airway, in 70, and they shared about 70% GI symptoms, cardiovascular symptoms in this GI system, according to the reviews in the guidelines, according to the WAO, and the assessments by Michael Schatz and Still Simons. Tryptase measures this is when it's changed, when it's taken as one of the markers, the symptoms where the normal values is represented between 1 to 11.4. When etiology can be any medication or insect bites, when this is in serial testing, and in the case of infarction or of embolisms. In the first few quarters, we need to have clinical criteria, urticaria, anxiety, or feeling of angioedema or syncope. During delivery, immediate postpartum, we must consider pathologies that are related with pulmonary edema, embolism, cardiomyopathy, acute coronary syndrome. It could be mitral stenosis, uterine hemorrhage, or embolism of amniotic fluid. The dilemma that we can face can be related with what I have mentioned: respiratory acute, skin, urticaria, angioedema, syncope, and also it can present because of the hormonal change, this acute panic or anxiety attack, or postpartum. It is necessary to see other immune possibilities that includes mastocytosis. With respect to the differential diagnosis and larynx situation, we can see preeclampsia, slow initiation, hypotension, are the ones that would correspond to this type of laryngopathies. If we're thinking that it can be hereditary, it's very rare, the presentation during pregnancy, but the symptoms generally so far, it's more from the abdominal point of view. When we're talking about the possibility of embolism of amniotic fluid, there's a possibility of cardiovascular collapse, dyspnea, disseminated intramuscular coagulation, and embolism of amniotic fluid. It can be tryptase, but it could be a reaction that is not IgE mediated, but it can trigger this cellular granulation. There are other markers that are being assessed, like hypotension. You must identify if there's hemorrhage, if it's secondary to the administration of an anesthetic or epidural. What should we do? It has been said throughout the week in a very complete manner, the different presentations. How is the management of anaphylaxis? There's not different to what we should be doing during pregnancy. The initial management, it's basically the same Pharmacologically speaking, we can see one line, adrenaline, where it could be category C for the pregnancy, antihistamine and drugs, category B, and the first choice, phenylethylamine, and the corticosteroids like methylprednisolone is the first choice after hydrocortisone. It's important fetal monitoring. It's important to assess if there's fetal distress and to include the initial symptomatic situation, because this is going to give us a pattern of heart rate. And when there's a resistance to treatment, we can see these assessments of fetal distress. The priority is, an emergency C-section from every point of view. Vital basic treatment, there's no question, is to follow the protocol of action in writing to make sure that it's there, to try to to eliminate contact as a cause of anaphylaxis, particularly ABCD of patent airway, breathing, and the assessment of the status of the patient. Adrenaline, as we know, emphasizing that is in the external side of the thigh, and it can be repeated, the dose, several times in a period of 5 to 15 minutes, depending on the answer. Supplementary oxygen through a face mask. Place the patients on the left side to keep them elevated, free airway to be able to administer the medications, as well as in the case of hypotension, to give saline solution to monitor the blood pressure, heart rate, to monitor fetal. However, we should always be ready for CPR if it's needed, and to assess at all time if the patient needs a C-section in the case of anaphylaxis where there's no response, or in cases when even there's a good response and when there's no response to traditional treatment. Even when we have a management of airway and blood pressure, we need to activate the patient. Maybe we need to see them, we need to replace volumes, particularly large volumes of fluids, and to understand that it's necessary to keep a pressure, systolic pressure, in order to keep perfusion of the placenta. What about the use of vasopressors during delivery? Well, it's used in those patients that have hypotension, adrenaline, and IV fluids. Currently, it's the one that is recommended the most in all these cases. In the case of this patient, Karen, 29 years old, she was an asthmatic patient, and she's still an asthmatic patient, non-controlled. It's very difficult to keep constant communication with her. All the steps that I have mentioned have been taken. 2 doses of adrenaline were given with 20 minutes of difference. She responded positively. The patient needed C-section, no complications. She's in immunotherapy, but she's not controlled properly and with not good compliance. The patient is 9 years old. He has allergic rhinitis and not good compliance with treatment. Obstetric management is important to compare the benefit that we will have on emergency C-section in those patients of treatment refractory anaphylaxis versus the risk of the procedure in those patients that have an hypotension and hypoxemia, according to the Macal trial. This publication in the Journal of Anesthesia of a few months ago, anaphylaxis during pregnancy. This is from Europe, where The patients from France, Belgium, and Finland were compared, as well as the UK. We see that 81% got epinephrine, 89%, 89% corticosteroids, only 64% receive antihistamine and drugs, and in 50% of the cases, we found an elevation of tryptase. We have to consider very carefully the risk benefit of immunotherapy, particularly when it's used with these procedures. Now, there's something else that is important that we must consider as prevention measures. We need to confirm the etiology of anaphylaxis. We need to have immunocap that is available not just for IgE, but for insects, latex, skin tests, challenge tests. Subcutaneous immunotherapy should not be started in immunotherapy with the potential possibility of adverse effects. And the baby and the mother, it should be stopped when it's in induction maintenance. If the patient was with immunotherapy, we can continue with immunotherapy as long as we have adjusted doses because of insect bites. Dr. Alejandro already mentioned that. I'm not going to take time here. There's no question that here the parameter is that the skin tests should be postponed and to confirm the sensitization to the venom of the insect. In special cases, beta-lactamic antibiotic-induced anaphylaxis. After the delivery, we can have prophylaxis, and then every 8 hours until delivery, vitamicin every 8 hours. If it's necessary, special cases because of latex, they need to be confirmed. If they have a specific sensitization, we need to provide information in writing that we need that in all the processes that the patient goes into the OR in the OR areas, that it should be in a latex-free environment. Within maternal complications, in this other study of the ASTRI, with respect to the factors and the complications, we have this trial where this results that demonstrate that the patients died and 7 of them had very severe problems. There's some rates of admissions that are higher depending on the situation. And as a matter of fact, from the other aspect of fetal complications that we must consider, we also have a reduction of the fetal flow, or because of maternal constriction, the fetus tries to compensate the situation through a network of distribution to the different organs, the most important organs, and with this hypoxia goes over these mechanisms, we are at a real risk of generating encephalopathy with permanent damage at the CNS or death. Oxygenation of the fetus is compromised directly by the mother's hypoxia and indirectly by hypotension, vasoconstriction that is going to be reduced. Also from neonatal complications, in this case, in the study from Acado, none of the neonates died. 7 were in the ICU, and there were several that were preterm delivery. There's more admissions in the neonatal ICU. What with respect to prevention? It has been mentioned by Dr. Macias about how to avoid or what type of insects, the colors of the skin, of the clothes, other substances that might be associated to these triggers. It's easy to say, it's difficult with sometimes the food products, the food safety, some foods are hidden, and to consider allergens. We have promoted 2 food safety scheme. What is the group of pregnant women that are at risk of anaphylaxis? Should we educate with respect to the use of auto-injectors, the first dose of epinephrine? We know that in the thigh and how to carry more devices, or through the kits that we have put together if we don't have auto-injectors because of the cost. All of those patients that are presented with anaphylaxis, with a history, must have a way to identify them that is going to help us as health personnel to confirm that they are and to try to determine in emergency situation all the possibilities that are presented. Some get a tattoo, and they might be, I'm allergic to this and this. Some others have bracelets or chains. When they go into the ER, what they get is they get remove everything, and often they're not identified. Some others have schemes that may have in writing the allergies and what can be used. Throughout the week, we've promoted everything about the use of adrenaline and why it's related, trying to identify the infographics, the causes and the symptoms of what the general population should know, the pediatric population, what is the treatment, and the exercise or not with anaphylaxis, what I have been discussing about pregnancy, about the difference in treatment, more than 10, 12 a day with respect to anaphylaxis with COVID, what is the risk, to promote that the allergy is not to the vaccine, but to the presence of polyethylene glycol that are always present in other products like perfumes, drops, laxatives, cosmetics, and many other products. Also, to educate the patients about what are the causes that could trigger once this process is established and they have used adrenaline correctly, what are the measures they should take under this framework of the World Allergy Week. This is a topic that we should emphasize not only this week, but every day of our professional life. In the education, not only to the physicians, the first contact physicians, pediatricians, internists, anesthesiologists, other specialties, the medical students, nursing, medicine, dentistry, the parents, and also relatives, caregivers, teachers, elementary teachers, PE teachers, training coaches of, different sports groups, biking, swimming, motorbiking, kickboxing. And for this tomorrow, I want to invite you to participate or to convey the information to the population at large, the possibility of being informed in an activity of a couple of hours tomorrow, June 19, 8:30 to 10:30 through Zoom. And YouTube, our General Center of Allergy Immunology, that is a center of excellence. What am I going to say now? Well, there's no question that with respect to this topic, during pregnancy, anaphylaxis is not common. Very few cases, not a lot of cases, some important cases like in Canada, UK, but we must know what are the things that make the patient be at risk. It's important to provide a timely treatment, to have good prognosis, not only for the mother, but for the baby. And if it's the case, we need to have a clear, immediate response monitoring the status of the mother and the fetus. The first choice is adrenaline. Number 2, corticosteroids and antihistaminic products according to how severe the reaction is. When there's a loss of the well-being of the fetus and it's decided to go through a C-section, you must consider the risks of delivering a premature baby, if it's under 28 weeks, if you need surfacting agents, you need to establish an emergency action protocol that is safe for both, trying to preserve life for the mother and the child, and to urge ourselves as professionals, allergy specialists that are certified, to have a better documentation of this case of staph anaphylaxis of pregnant women, to be there, like our OBGYNs, our service of trauma and emergencies. I would like to say more, but because of the time constraints, this is what I have for you tonight. But if you have any questions, through the chat or directly to my email address. Thank you, Dr. Sara. Thank you as coordinator, as Compedia, the opportunity of participating in this meeting to bring awareness about the situations that we should consider not only this week, but every day of our professional lives. Thank you. Thank you, Dr. Sandra, for your excellent presentation. The information is clear, to the point, and of great help to us and to all the doctors that are online. Thank you for inviting us tomorrow, and hopefully many of us are going to be connected tomorrow in this class for parents and patients. Questions that we may have for Dr. Sandra Gonzalez, please write them on the Q&A icon. Thank you, doctor. We now have a presentation in English. If you want, you can have Spanish interpretation by using the icon on the screen. It says interpretation.
Última plática del día de hoy y de la
As
semana.
our last presentation today, we're going to have Dr. Jennifer George in Canada. She joined the Food Allergy of Canada in 2014 as a voluntary member of the board before she took the post of executive director. When she joined this organization, she has been very important in leading strategic activities in Allergy Foundation in Canada, providing education and support to people and families that live with food allergies, and at the same time in promotion topics. We remind you that this is the last session, and at the end, we're going to have a link for the final questionnaire. Thank you. Dr. Jennifer, you have the floor.
Thank you for the invitation to speak with you today about educating patients on anaphylaxis. I'm Jennifer Gertz, Executive Director of Food Allergy Canada, and my co-presenter today on this topic is Dr. Julia Upton. Dr. Upton is a pediatric allergist at the Hospital for Sick Kids in Toronto, and associate professor in the Department of Pediatrics at the University of Toronto, as well as the past chair of the Anaphylaxis and Food Allergy section of the Canadian Society of Allergy and Clinical Immunology. I'm Jennifer Gertz, Executive Director of Food Allergy Canada. I've been in this role since 2018, and prior to that served on the board of Food Allergy Canada. And I'm also a mother of 3 children, of which 2 of my children live with multiple food allergies. So a little bit of background on Food Allergy Canada. Our organization was officially founded in 2001 and was named Anaphylaxis Canada. In 2015, we changed our name to Food Allergy Canada with a renewed focus on helping those with food allergy live confidently. We are a national charity and the country's leading patient organization committed to educating, supporting, and advocating for the more than 3 million Canadians impacted by food allergy. We focus on improving daily quality of life by providing education and support needed to effectively navigate this medical condition, building informed and supportive communities, and acting as a national voice on key patient issues. In addition to being governed by a board of directors, we also work very closely with the Healthcare Advisory Board. Our Healthcare Advisory Board is comprised of a distinguished group of allergists, clinicians, and researchers from across Canada. And this is a really important relationship and sets the foundation for ensuring that the work we do is medically reviewed and that there is an opportunity to provide input into activities and collaborating on key patient needs. So today's session, we will be addressing the following learning outcomes. First is about establishing epinephrine as the first-line treatment for anaphylaxis, translating the clinical definition into language that patients understand, and sharing the lessons learned from Food Allergy Canada on common patient barriers to the use of epinephrine and some of the educational approaches that have improved patient confidence, as well as we'll touch on some advocacy-related activities that we have undertaken to improve the access to epinephrine autoinjectors. Now, before I turn the presentation over to Dr. Upton, I just want to ensure that the viewing audience has context for the epinephrine environment in Canada. Up until recently in 2020, we had one supplier of epinephrine autoinjectors in Canada. That was EpiPen. We now have three, so with the addition of Allerject and Emerade. So with these options, we are in a much different situation to what we understand. This is the situation in Mexico, as we don't recommend the use of vials. So later in the presentation, we will cover off some advocacy efforts that we undertook in Canada during the worldwide shortage of EpiPens that led to the availability of three suppliers. Now, there may be some learning in that you may be able to consider for your own environment. So now I'm going to turn it over to Dr. Upton, who is going to walk us through the clinical definition and treatment of anaphylaxis, as well as the translation of that definition into patient-friendly language.
Great, thank you so much. We're going to go through the clinical definition and treatment of anaphylaxis. So the World Allergy Organization recently updated their definition of anaphylaxis, and it's presented here. Anaphylaxis is a serious systemic hypersensitivity reaction that is usually rapid in onset and may cause death. Severe anaphylaxis is characterized by potentially life-threatening compromise in airway, breathing, and or the circulation, and may occur with typical skin features or circulatory shock being present. And that's the 2020 definition. Anaphylaxis affects multiple body systems, and this table here illustrates the common ones. So in terms of skin, the patient can experience sudden itching of eyes and nose, flushing, hives, angioedema. From the gastrointestinal system, there can be itching of the mouth, tingling in the mouth, bit of lip swelling, nausea, vomiting, abdominal pain. And from a breathing point of view, nasal congestion, sneezing, rhinorrhea, throat itch, as well as throat tightness and wheezing. So those would be in a grading of anaphylaxis severity, they can be from mild to moderate to severe. And all of these categories aren't necessarily consistent across every severity grading. And there's a lot of interest in the world in trying to understand mild anaphylaxis, moderate anaphylaxis, and severe anaphylaxis. Certainly, though, when it becomes very severe, there can be significant symptoms with cardiovascular collapse and respiratory collapse. It's really important that when we discuss anaphylaxis, we can turn all of that information into recognizing it and what do you do about it. And so translating definitions into action is seen both for physicians as well as for patient groups. And so here is an example in Canada of a pediatric anaphylaxis algorithm where the definitions of anaphylaxis and what to do about it have been translated to emergency doctors because we really rely on community treatments for these patients. And the goal of this is to be able to quickly recognize anaphylaxis or suspected anaphylaxis and act. And so when doctors are seeing the patients in the emergency room, they're not thinking about, does this meet exact definition? What they're thinking about is keeping the patient safe and, is it likely that this is a reaction that would benefit from treatment? And so this algorithm is quite helpful with describing the recognition of anaphylaxis. So a patient who has acute onset of skin changes, plus respiratory or cardiovascular or GI symptoms, or any of the three, or just hypotension alone, bronchospasm alone, upper airway obstruction alone with exposure to a known allergen. And the real goal of this is to be able to initiate the management. And so lying down, assessing the airway, breathing, circulation, and then providing oxygen if needed, as well as epinephrine. So IM epinephrine is, meaning intramuscular epinephrine, is the first line treatment for anaphylaxis. And we'll go through why. So the important thing about treating anaphylaxis is that we need to be able to reverse or treat the body systems that are involved. And so epinephrine actually is able to relax the smooth muscle and open the airways. In terms of the circulation, it actually constricts the blood vessels and raises the blood pressure, increases the heart contractions, raises the heart rate. And in terms of the skin, again, because it is able to tighten the blood vessels, it reduces the hives as well. Importantly, anaphylaxis is actually stopped by epinephrine. It has the ability to interfere with the ongoing reaction. So when we compare that to antihistamines, really the main effect of antihistamines is that it reduces the hives. So it's really important to be able to express to patients as well as emergency care providers that epinephrine is the first line treatment because it's treating all the parts that we worry about, the breathing symptoms, the circulation symptoms, as well as has the ability to stop this in its tracks. And a really common patient myth is the belief that antihistamines alone can treat anaphylaxis. But they really don't relieve the stridor, the shortness of breath, the wheezing, the gastrointestinal symptoms in a reliable way to be able to be used in an emergency situation. So in addition to what antihistamines do versus what epinephrine does, there's the time of onset of the medications. So here, I've shown with a turtle versus a rabbit or a hare, but basically because antihistamines are oral, they're going to take 15 minutes, 30 minutes, maybe even longer to reach a relevant amount in the circulation. Whereas epinephrine, because you're giving it intramuscular, it has a much quicker onset of action. And it's really important to have a quick onset of action because time counts. So when we learn from fatal reactions, thankfully these are rare, but when they do happen, the progression is fast. And the median time to respiratory or cardiac arrest is only about 30 minutes for food, and less so when the allergen has been introduced to the circulation more directly. So from a sting with venom, the reaction happens very fast, and intravenous drugs is even faster. So early treatment is essential, and early treatment reduces the potential for biphasic reactions, meaning when the reaction comes back, as well as hospital admissions. And so one of the goals that we have is to really reinforce the importance of community treatment from both the physicians and the patients when they're treating anaphylaxis. So in order to be able to communicate with the patients needs to be, again, just like with emergency dogs, just like with everyone, we need to put it in languages that help them to act. So anaphylaxis in patient-friendly terms are to say, this could be anaphylaxis if it has sudden onsets within minutes to hours. If you have symptoms involving 2 or more body systems, like skin, breathing, GI, or cardiovascular, or one really severe symptom, when you know that you could have been exposed to your allergen. And so a very severe symptom would be a drop in blood pressure or difficulty breathing, either because of local airway or because of the lungs. And then we advise 5 emergency steps. So step 1 is to give epinephrine at the first sign of a known or suspected anaphylactic reaction. We don't need to be academics and diagnose the exact reaction. We need to treat. And so in step 2, we would call 911 or emergency medical services and tell them that someone is having an anaphylactic reaction. Ideally, people have 2 epinephrine auto-injectors on hand so that they can give a second dose about 5 minutes after the first dose if there's been no improvement. And the treatment of anaphylaxis is ideally done in a medical setting. And so, we think of the administration of IM epinephrine as a temporizing measure or as a first step, but really they need to go to the hospital. And then, of course, with a family, letting the family know that this has happened. So patients need to learn the location of the injection. And so this is the upper outer part of the thigh. And we like to use IM epinephrine in the thigh because the muscle is big and gives more rapid absorption than smaller muscles. And it's important that it's intramuscular rather than subcutaneous because that again increases the absorption. The body position, to receive epinephrine, the person should be sitting or lying down, and then and stay sitting or lying down. And if they do have a lot of trouble breathing, then some people are more comfortable sitting up and leaning forward. And if they feel like they're going to vomit, then being on their side is better to avoid aspiration.
Great. Thank you, Dr. Upton. So I'm going to move on to a discussion around addressing the gaps in community management of anaphylaxis. And through both research publications and learning through our own educational programming, the barriers that we see to using epinephrine for community treatment of anaphylaxis fall into 3 themes. The first is confusion on recognizing anaphylaxis, really understanding signs and symptoms. The second is around low availability or not carrying their autoinjectors. And the third is around prescription rates, patients choosing not to fill their prescriptions for a host of reasons. Now, of note, we don't find that the how to use epinephrine autoinjectors as being a barrier to use, which may be a significant factor within your environment. So Food Allergy Canada's role in supporting anaphylaxis management falls into 2 buckets. One, awareness and education, so increasing community awareness and developing and implementing community-based programming, and then in policy on advocating to improve access to epinephrine and support for impacted communities. And we particularly focus on the school environments here. So when it comes to awareness and education, the first step is establishing the key messages that need to be reinforced based upon what the barriers or knowledge gaps that exist in your environment. So what is the simple key? What do you want to communicate? What are those messages? And then the second step is around what are the best vehicles to share these messages, how you communicate it, considering reach, matching the vehicle to the complexity of the message, and considering cost. In the case of Canada, our 3 main barriers to using epinephrine are confusion on signs and symptoms, confusion on treatment, and concerns around safety. So what we want to communicate and the key messages that we think about in all of our outreach efforts is, first, use epinephrine promptly if you think it's anaphylaxis. Going back to if it's suspected, it's better to err on the side of caution. We reinforce, if unsure, better to use than not use. Second is epinephrine is the first-line treatment for anaphylaxis. And third key message is around you will not cause harm by using epinephrine. So we have a number of different activities underway, and my intent here is really to share with you the various vehicles that we've used. Some require more investment than others, but it's really to give you an idea of possible approaches around community education. So we have website and social media efforts. We've created downloadable patient information sheets for healthcare providers to use with patients. We've created youth videos with impacted youth to share their reaction stories and how they've treated it. We do event programming, so in the form of webinars or social media through Instagram or Facebook Live. We also have Food Allergy Awareness Month, which is the month of May, and we do a significant campaign during that month to raise awareness, and we spend some time in the school and childcare settings with a program called Allergy Aware. So again, to give you an idea of what it looks like from a website standpoint, we have content on what are the reaction signs and symptoms. So it would have those simple graphics that Dr. Upton showed you around the body systems and the signs and symptoms. So we continue to use the same images in our educational pieces. We also, as you can see up here, we've done a understanding when to use epinephrine. So we do event-related things that we then post on our website. So it becomes an asset that's content that can be viewed time and time again. And here you can see a patient information sheet. This past May, which was our Food Allergy Awareness Month, we ran a campaign called Know It, Treat It. It's our effort to educate the community on anaphylaxis. And so the Know It, Treat It campaign is all about demystifying anaphylaxis and empowering Canadians to know what the signs and symptoms are and know how to treat it. Because our goal here is to have all Canadians feeling confident about managing anaphylaxis. So again, the campaign reinforces our key messages: understanding signs and symptoms, and treat it with epinephrine, the first-line treatment for anaphylaxis. And then here are some social media platforms, which are cost-effective ways to build reach in an audience. And these are just a few of examples. We did a video series with some of impacted youth who were showing how they treated their reactions with epinephrine. We've done some Instagram live series with Canadians sharing their anaphylaxis stories. And then most recently, we also did a Facebook Live program with Dr. Upton on how to use epinephrine auto-injectors. So this was really reinforcing, what the treatment is, but also was a demonstration on how to use epinephrine. So what we've learned is that, the more resources from Food Allergy Canada that an individual has used, the more supported that they feel. And additionally, our webinars, which are really important educational content because it gives you lots of time to talk to participants and really go into detail on signs and symptoms, but how to use and when to use. We found that 96% of the participants, it really increased their confidence on being able to understand when to use epinephrine. And what they fed back to us was the most useful information was understanding signs and symptoms, the 5 emergency steps, and the reinforcement of epinephrine is a safe first-line treatment for anaphylaxis, not antihistamines. So I want to go on to a bit of a conversation on laws and policies. And I realize that establishing laws and policies may not be the focus of your daily work. I do want to cover this off because when you look about how Canada elevated anaphylaxis as a priority and significantly advanced the community's understanding of it, the role of laws and policy is significant. So I'll take you back to 2005. In 2005, Sabrina's Law was passed in the province of Ontario, and it was a policy event that significantly changed the landscape in Canada. Sabrina Shannon suffered a fatal anaphylactic reaction during her first year of high school in 2003. The trigger of that reaction was determined to be a dairy protein. They believe likely to be a result of a cross-contamination from tongs used to serve her French fries from the school cafeteria. Notably, there was a delay in using epinephrine, and this whole situation motivated an effort to make schools safer. So in May 2005, the Ontario government passed a bill, an Act to Protect Anaphylactic Students, which applies to all publicly funded schools in Ontario, and it's named Sabrina's Law. What this law requires is that every school board in Ontario establish and maintain an anaphylaxis policy to help students with serious allergies. And it also required schools to create individual plans for each student at risk of anaphylaxis. Now, as a result of Sabrina's Law, in the province of Ontario, which is Canada's largest populated province, hundreds of thousands of individual plans and educational programs have been created in schools across North America and was a precipitous to things happening around the world. Furthermore, the law has been enhanced with a measure in 2020. Alberta passed a very similar law, and they had a measure of stock epinephrine in place. So an epinephrine auto-injector not prescribed to a particular person that could be used in an emergency. So there is further enhancements that are now trying to increase access of epinephrine in the school environments through a stock epinephrine mechanism. So that really changed the landscape in Canada and the understanding of anaphylaxis. That was then translated into building educational tools to support teachers and childcare workers, but again, obligating the school system to take a responsibility and have accountability has really led to raising the profile of allergy and anaphylaxis, including epinephrine as first-line treatment. The second thing I would want to draw your attention to is another game-changing event that took place in 2018 during the global shortage of EpiPens that impacted Canada. At that time, we only had one epinephrine auto-injector option available, while the US had several different options. So it's important to note that epinephrine auto-injectors were already recognized as an essential medication in the minds of Canadians and politicians. And so we use this as a platform, this shortage as a platform, not only to address the shortage, the acute shortage, but to call for an action to have a minimum of 2 suppliers in the Canadian marketplace. And here's just some of the headlines that you can see that really reinforced and brought to the attention this need to have access for affordable, reliable access to epinephrine auto-injectors. And what we were able to do through this situation is we were able to get an interim supply for the importation of a US manufacturer, Auvi-Q, and with ongoing advocacy, it paved the way for 3 suppliers. So what we learned through this is having patients driving this and putting it on the agenda, working with the lead government departments who had the responsibility for the supply of essential medication. And with that, bringing facts to the table to help that government organization understand the nature of the industry and the issue, and understand the global supply network that was a compounding problem, and then also putting forward and giving them ideas around how could they possibly address this. We were able to bring international insight through connections with other patient organizations to understand how this issue is being felt throughout the world. And we were able to collaborate with that international insight, facts, and patients as the center. We were able to collaborate with government for mutual benefit. What really helped bring the change, though, was there was political motivation for this change. So if I had to look back and try to capture what are the building blocks or the essential elements that took place in Canada that set the foundation for change, the first thing is we established broad-based awareness of anaphylaxis and the understanding of its potential to be life-threatening. And that certainly, the passing of Sabrina's Law helped to do that. Through that, there was an acknowledgement within the community that epinephrine is an essential medication. And although it's not consistently recognized as the first-line treatment of anaphylaxis, it is becoming recognized as the first-line treatment for anaphylaxis. We had established relationships with government and the pharmaceutical industry, and we were able to use a high-profile event that created political motivation for the government to engage. So if you're considering a collective advocacy effort of your own to address either school policy or the access to epinephrine auto-injectors, please feel free to reach out. We would be happy to share more insights that may be helpful to you in your own efforts within Mexico to address the availability of epinephrine. So to wrap up with a couple of slides, first of all, some of the takeaway messages from this: epinephrine, first-line treatment for anaphylaxis. A sustained and multifaceted educational approach can build community knowledge and anaphylaxis management. Policies or laws can be effective in generating broad-based community engagement in anaphylaxis, and patient organizations and patients in general play a key role in advocating with government for access to epinephrine. Just one last thing of note, Food Allergy Canada does have one of our publications available in Spanish, Living Confidently with Food Allergy. It is a downloadable off our website, and it may have some applicability to help you and support you in your own environment. Thanks very much again for the opportunity to speak with you today.
Muchísimas gracias. Gracias a todos.
Thank you everyone.
Les recordamos el
We remind
email para
you,
poder mandar las
this is the email to send your question, preguntasSMA@compedia.mx. Thank you for being here all week. It was a very intense week, a lot of information, but I think it was good for all. It was a lot of effort. It wouldn't have been possible without all of these Mexican teachers that we had this week and the foreign professors. So I give you a big hand, and we were able to have this wonderful project. Thank you, Sarita, for coordinating today. Thank you for the speakers of this week. I'm eternally thankful, and you for having logged on. And as Sandra said, we have to be not only this week, but every day of our daily practice, we have to be paying attention. And as personnel in charge of allergies, we have to be the experts in knowing how to manage and educate our patients and other physicians. Thank you. You have to respond to this survey today in order to have your certificate. This is the link for the closing survey. We are certified by both councils, CONICA and Compedia. We have 8 points. Thank you to the speakers. Thank you to the speakers that were wonderful. All of you who logged on, thank you so much. And we promise to keep putting together this type of meetings that all us allergy specialists enjoy so much. Thank you. Congratulations to all dads on Sunday, on Father's Day, and thank you for logging on.